Good evening, dear colleagues. My name is Pol Rommens. I am the former director of the Department of Orthopedics and Traumatology at University Medical Center of the Johannes Gutenberg University in Mainz, which is situated in the Midwest of Germany. Before we focus on fragility fractures, I would like to get you acquainted with the definition of the World Health Organization. A fragility fracture is a fracture that is caused by an injury that would be insufficient to fracture normal bone, the result of reduced compressive and/or torsional strength of bone. So when we talk about fragility fractures, that includes osteoporotic fractures, insufficiency fractures, and so-called geriatric fractures. When we focus on this, we have to think about the aging population in our industrialized countries. You see here the graphic of the median age of populations in 2020s in large countries of the world. And you see that Japan and Germany have the oldest populations, which is 48.4 and 45.7 years of age. That means for Japan, that has 100 million inhabitants, that 50 million of their population are older than 48.4 years. And the same for Germany, about 45 million people are older than 45.7 years. That brings us to new problems because we are facing two diseases and comorbidities of the aging population. Here you see a publication out of 2014 from the United States. The authors have looked at the discharge diagnosis of all Medicare patients, that means 65 years and older, in the United States between 1993 and 2010. So it's an 18-year period. There were about 250 million discharges from hospital in this time. In the traditional hip fractures, so the pertrochanteric and femoral neck fractures count for about 3.5 million. The pelvic fractures only for 500,000 and the acetabular fractures for less than 100,000. But if we look at the incidence of these fractures over time, then you see that the traditional geriatric fractures have a peak in 1996 and then continuously decline to have a decrease of 25% in 2010. But the opposite is true for closed pelvic fractures. You see a steady increase over time and also about 25% in these 18 years. Certainly, the absolute numbers are still very different. We are talking about 500,000 classical geriatric fractures on the hip and only 100,000 pelvic fractures in this period of time. But the increase of incidence of the pelvic fractures is very clear. And here we see some more recent publications out of the European Union, which show the similar trends. You see here a study of Finland from 2015, which shows the age-specific incidence, and you see for women and for men, you see a steep increase, and it continues to increase until 2030 of all categories, especially patients above 80 years of age. The same is true in Germany, where we have the following publication on the epidemiology of pelvic fractures, and you see the title, Considerably High Incident Rates Among Older People. And one of the graphics in this publication shows a steep increase of the incidence of pelvic fractures in all patients of 80 and above, even of 75 and above, be it women or men. This is the graphic of the German pelvic trauma registry. There are 3 different periods in this registry: 91 to 93, 98 to 2002, and 2004 to 2010. And here you see the incidence of the pelvic fractures depending on the age and on the sex. And you see in the first period, 91 to 93, that the majority of the pelvic fractures occur in young men, excuse me. And in 2004 to 2010, there is a clear shift towards older women. So in a period of 20 years, we face a totally different patient population. A more recent publication in 2021 looks back at the incidence and mortality risk after pelvic fractures in Austria. And also here, there is a clear increase in the incidence of pelvic fractures in the elderly population, with a greater increase in men over time. The same is true for Switzerland. Another publication from the European Union and outside current results corroborate the trend of increasing frequency of fragility fractures in the aging society. The demographic shift has a direct impact on the fracture pattern, with a disproportionate increase in partially stable compression fractures. A publication of 2016 from the United States shows that there is an increase in incidence in pelvic fractures. Here we look at all pelvic fractures, not only the elderly patients. But what is striking in this publication is that mortality declined in this population with pelvic fractures from 4.2 to 2.8% in this 20-year period of time, and that this was depending on surgical fixation. So when a patient was treated surgically, the mortality decreased. A last study that I want to show you, because Belgium is my native country. Also here, we see an increasing incidence of pelvic and acetabular fractures, with the majority of these fractures occurring in the older people. So this is not only a trend, it's already a reality that in most of our countries, we are facing a clear and steep increase of the incidence of pelvic fractures in the elderly, especially in women. That leads us to the question, what are the differences between pelvic lesions in adults and in the elderly? We can say that in adults, we are facing high energy trauma. And in the elderly, we are facing low energy trauma. So falls at home from a standing position as a typical example. The most striking difference in the patients themselves is the strong bone in the adults and the strong cancellous bone, and the weak and very weak cortical and cancellous bone in the elderly population. So that gives a different morphology to these fractures. I will come back to that later. And even if the patient is treated conservatively, there may be an increase of instability over time. Here you see a study that has been done in the AO Research Institute in Davos with one of my collaborators. We looked at 92 Europeans, and here you see three-dimensional models of the sacrum that were clustered in two groups. In one group with patients that had a higher bone mineral density in L5, and one group that had a lower bone mineral density in L5. This was measured in Hounsfield units. In the group with a higher bone mineral density, we only see small islands here in yellow of, we call that sacral voids. These are areas where no bone is present anymore. The intensity here is equal to that of water. If we look in the group with a lower bone mineral density, we discover large areas of alar voids in the sacral ala left and right, some islands in the middle of the sacrum, sometimes even that connection between the alar voids on the left and the right side. And that explains the typical morphology of the sacral fractures in the patients with fragility fractures of the pelvis. You see unilateral vertical fractures in the sacral ala, so lateral to the neuroforamina. This can be unilateral, it can be bilateral, and there can be an incomplete or a complete transition between the vertical fractures. And you see here in the last drawing, this is a H-type injury. In the adults, we call that spinopelvic dissociation. But the clinic that we see here in the older population with H-type injuries is totally different than that in the adults. Two examples, you see here an 83-year-old female, 3 months after the onset of complaints. For the first time, a CT scan and conventional X-rays were taken. In the conventional X-ray, you see a huge displacement on the left pubic rami. If you see the CT scan, this is a transverse, a coronal, and an oblique reconstruction. Then you see these complete fractures in the sacral ala on both sides. Here, the internal rotation of the left hemipelvis and the displacement near to the symphysis pubis in the front. So that's a highly unstable lesion of an 83-year-old patient. Another patient is 81-year-old, recurrent falls at home, pain since months that were, the lesions were treated conservatively. Patient was not seen by any doctor. Then she came to us and we took CT scan. You see the reconstructions here, severely displaced fracture on the pubis on the left, 2 complete fractures in the sacral ala, left and right, and you see these alar voids very nicely here. A horizontal fracture between S1 and S2, and here in the reconstruction you see the combination of the lesions in one plane. Also here, we can say this is a highly unstable lesion, but the patient here is still able to walk independently with crutches, which is certainly, if you have this type of injury in the adult, there would be an impossibility to move. These were reasons for us to look back at 245 patients in our hospital that suffered a fragility fracture of the pelvis. And we were able to recognize different categories of instability and develop, therefore, a comprehensive classification combined with recommendations for surgical treatment. And you see here the first criterion of our classification was the degree of instability based on pictures of conventional X-rays and CT. The second criterion was the localization of the fracture in the posterior pelvic ring, because there, if you decide a surgical treatment, it depends on the localization of the lesion, where you will and how you will stabilize this fracture. We could distinguish 4 different categories: an FFP, that stands for fragility fracture of the pelvis. The first category is an isolated anterior lesion. The second category, an undisplaced posterior lesion, combined or not combined with an anterior lesion. And the third and the fourth category are displaced lesions. The third category, unilateral, and the fourth category, bilateral posterior lesions. As you have seen in the previous examples already. The question then comes up, should we operate on these frail and old patients? And when do we operate? How do we operate? And which technique should we choose? This is a publication that we published in an Indian journal. You see the different authors here. And here you see the organigram or the algorithm that we choose for the treatment of these patients. On the left side in blue, you have the stable lesions. Stable lesions after the evaluation in CT and conventional X-rays. And most of them do not have severe pain. They are able to walk, and after a good conservative treatment, they are able to be discharged from hospital. But that's not the majority. The majority lays here in the red group. Some of them come from the blue group because treatment was unsuccessful. But if you have unstable lesions, type 3 or type 4, then you should perform surgery immediately, or you should propose or try to convince the patient to perform surgery. And there we are sure that anterior fixation and posterior fixation is necessary. We looked back at 519 patients from our department with these types of lesion. And the type 2, which is the group with undisplaced posterior lesions, counted for 238 patients, which is about 50%, somewhat lower than 50%. This is a very important group, and there is still discussion in literature on how to treat these patients. You see here in this retrospective study, we treated 78 patients conservatively and only 21 patients operatively. The median length of hospital stay in this whole group was 10 days, was a 1-year mortality of 14.2%. And you see here with these two parameters, there is a significant reduction in quality of life and mobility. But if we now compare the non-operative group with the operative group, you see this is a minority. At that time, this was a retrospective study. We found a significant difference in mortality after 1 year, 2 years, and 5 years in the operative versus the conservative group. That means that the operative group has a better survival after their surgical treatment. If we look now at the patients with type 3 and type 4 in this large group of 519 patients, this is about 1/4 of our patients. There we only had 30% conservative treatment and about 70% operative treatment. The median length of hospital stay was longer than in the group with FFP2 lesions. The 1-year mortality was similar, 15%, but there was also a significant reduction in the quality of life and in the mobility of these patients. But again, and here you see the Kaplan-Meier curve, after 1 year, 2 years, and 5 years, we found a better survival of the operatively treated patients. So in both groups, the unstable lesions and the stable lesions, FFP2 patients with stable lesions, undisplaced posterior lesions, both profit from a surgical treatment. In Mainz, we favorized in this retrospective time, this is between 2010 and 2020, we favorized a transsacral implant, transsacral bar. You see here, this is the corridor of S1 in the lateral view, and the bar is this black spot. It is about 6 millimeter of diameter and had a thread from the beginning to the end. On both sides, there are washers and nuts, and you see here that this washer is pushing against the lateral cortex of the posterior ilium on both sides, and the bar is going through the corridor of S1. An example here is a 68-year-old female with a FFP type 2C lesion. You see the complete fracture here, an incomplete fracture there. It was a conservative treatment which was unsuccessful. And here you see the pelvic AP inlet and outlet view after the surgery. You see the position of the transsacral bar, an additional iliosacral screw, and a retrograde transpubic screw to bridge the fracture in the front. Here in the inlet view, you very nicely see that this transsacral bar can, or the nuts on the transsacral bar can put some compression on the posterior ilium, posterior sacrum. Another example, a 77-year-old female with an FFP type 3 lesion, so a displaced lesion. You see a large displacement and instability at the symphysis pubis, and you see a older fracture on the left sacral ala in this patient. So she had 2 months conservative treatment without success. And here we were obliged to perform a double plate osteosynthesis in the front, but you should focus on the back, and you see the position of the sacral bar through this corridor, going from left to right with nuts and a washer that increases the stability. We look back at 85 patients that underwent such a procedure. We needed a revision in 13 of them, which is 15%. This is also retrospective study, so in our view, a too high number. The 1-year mortality, nevertheless, was below 10%, and this was in the only group with such low mortality in our retrospect study. Just go back for a moment. And after 3 years of follow-up, 85% of these patients lived at home, and 82% walked with or without a walking aid. So if you look at these patients that had this type of fixation, you can say low mortality rate and very good mobility and independency after 3 years, most of them living at home. Nevertheless, a too high operative revision rate. We looked at this space that was available for transsacral implants to treat this fracture with this transsacral bar. And again, Daniel Wagner, that this three-dimensional study on 92 Europeans looked here at 156 individuals and looked at the CT scan and calculated if a transsacral corridor was available in these patients. And you see here the results, which are very striking. 51% of the pelvis accommodated a transsacral implant with a safe zone above, below, in front and back of the implant. 22% did not offer enough space in S1 for an implant, even when ignoring the safe zone. And in S2, there could be a corridor in most of the cases, but there the diameter is smaller and not all of the fractures are suitable for this type of stabilization because most of the fractures are situated above S2. But here, so it's very striking that we are not able to implant a straight transsacral bar in about half of our patients when we ignore the safe zone in about 1/4 of our patients. The same we did with the anterior pelvis. Mrs. Charlotte Arendt of our group looked at the transpubic corridor for implantation of a straight cancellous screw, as I have showed you in some of the examples before. So she calculated this corridor in 150 uninjured pelvis, which means 300 corridors, because you have 2 corridors on each pelvis. And also here, you see here the pelvic, radiographic reconstructions of a patient with 2 retrograde transpubic screws. And you see here that a transpubic corridor with a diameter of 7.5 millimeter was available in 185 of 300 investigated superior pubic rami. Also here, we see that in a large minority of our patients, it is impossible to insert a straight long implant through this transpubic corridor. So that means that a minority of our patients, a large minority, will not fit for a straight implant in the back and a straight implant in the front. And that, I think, is the place where CurvaFix comes and has a big advantage. It's the only implant that follows the natural curvature of the pelvis. You see here, I think all of you will know that the implant just takes the curve, the natural curve of the posterior and also the anterior pelvis. And I think that this is a very good alternative to our straight implants that we used in our retrospective time period between 2010 and 2020. And I would be happy that also in Europe, this implant becomes available for stabilization of fragility fractures of the pelvis, as well in the posterior as in the anterior curve. This is my last slide. It shows the incidence or the absolute numbers of pelvic fractures in the United States in 2019, together with hip fractures. You see the hip fractures are in number much higher than the pelvic fractures. But if you look at the geriatric population here, then you see that the pelvic fractures are treated operatively in 95% of the cases, and the geriatric fractures, pelvic fractures, are only treated in 5% of the cases operatively. So 95% of the hip fractures are treated operatively. Only 5% of the pelvic fractures until now are treated operatively, and these are numbers of 2019. So I would like to conclude that here, especially for the pelvic fractures in the elderly, there is still room for further gains. Thank you very much for your attention.